In a perfect world, everyone's teeth would last forever. We would not need to replace any. But in the real world, right now, there are teeth that are being lost to caries, to periodontal disease, and to trauma. And all of these need to be replaced. And of course, when one of the major ways that we are doing these replacements today are implants. And whenever we do something with the human body, there is always a reaction, and very often that reaction, or maybe not often, but sometimes that reaction can persist and become a pathology. Pathologies in relation to implants are very old. They have been around for a long time. But I guess, and so the topic is not new, but what is new is that we have, for I think what must be the first time, a brilliant oral pathologist and an equally brilliant implantologist who is going to be discussing this with us. Welcome to the webinar, Dr. Narayan.
Thank you, Dr. Mandana. Thank you for having me. Yeah.
Yeah, before we start, we will also have a quick introduction to our experts for the session. We have Dr. Sudhindra S. Kulkarni. He's a periodontist and a diplomat ICOI, professor and head Department of Implantology, professor Department of Periodontics. He is a postgraduate guide and trainer and a mentor at his academy in Hubli. He has numerous publications and has been a guest speaker at many conferences and events. He'll be moderating the session. We also have Dr. Tarun Kumar, who is considered one of the leading authorities in bone regeneration. He's a periodontist but restricts his clinical work to dental implant therapy and bone and soft tissue reconstruction. He is the founder and academic chairman of the Papuji Implant Center and professor at Papuji Dental College. He is a fellow and diplomat of ICOI and fellow of the World Academy of Ultrasonic Bone Surgery. He is a winner of many international awards and also on the panel of faculty of many institutes. And he is also well published and speaks at many places. So with that, I'm going to just hand over to Dr. Kulkarni. Please take over.
Wish you all a very, very good morning. And it's been a pleasure to host this wonderful meeting. And thanks to Dr. Mandana for having me here as the moderator of this session. It's a pleasure to moderate any session by Narayan. And actually, everyone knows Narayan in India. I don't think you would require a specific introduction. But for those of us, for those who are unfortunate not know him, I would say that he is someone who's straddled actually various fields of dentistry, very diverse. On one side, he is an excellent oral pathologist as well as a wonderful clinician, and more so an implantologist and restorative dentist. He runs a very successful practice at Bangalore, focused on implants and restorative dentistry. He was formerly the professor and head of the Department of Oral Pathology at Oxford Dental College. He did his graduation from M.R. Ambedkar Dental College, Bangalore in 1992, and then continued with his post-graduation in oral pathology from Nair Hospital Dental College, Mumbai. And apart from that, he is serving as on the editorial board of Quintessence International, India edition, and he is also very, very sort of speaker in and abroad. He is one of the top-notch faculty online as well as physical training in implant dentistry and oral rehabilitation. He is also the founder member and director of the ITI Study Club India, Bangalore edition, and also the founder director of Implant and Aesthetic Academy, Bangalore. I think with these few words, I would rather have Narayan speak about this today's topic than wasting any more time. And it's also a pleasure to have Tarun on the board with us here. Thank you very much, Dr. Narayan. The screen and the mic are yours.
Thank you, Sudhindra. It's always a pleasure to hear your voice, first of all. See your face is doubly so. And the same with Tarun and Mandana. It's we meeting virtually like this, I think I don't think it really makes a difference that we've not met for a long time, because we are kind of there's a connect that goes beyond the physical. And so thank you so much for those very kind words. I don't know how much I deserve of all of that, but I'll try to live up to a little bit of it as we go along today. Uh, so, like I mentioned somewhere, that these are two things that are very close to my heart: pathology and implant dentistry. And given that, to be able to be given an opportunity to speak about the two in one breath, I must thank Mandana for the suggestion and the goading, the prodding to make sure that I'm here today on time to be able to deliver this little ditty, if you want to call it. So for the next 45 minutes to about an hour, I will talk through. I'll talk you through an overview of implant-related pathologies. And for us to understand implant-related pathologies or pathologies around anything, it is imperative that we first understand what constitutes the structures that surround the implant. And for that reason, we will start our discussion with understanding the exact nature of the peri-implant tissue and the supracrustal complex as we know it. We'll talk a little bit about the predisposers to peri-implant disease and the etiopathogenesis of peri-implant disease. Then we'll talk a little bit about titanium, its corrosion and mechanical wear, and its impact on peri-implant tissues, as well as far-reaching distant effects of it that we know of. A little bit about drugs and their impact on the phenomenon of osseointegration. And to wrap it all up, I will speak a little bit about the association of oral cancer and dental implants, which seems to be generating some interest in the circuits right now. To start with, we will define a term that has been used in literature for teeth for the longest time. That is the term biologic width, which is basically an imperative. It has to establish itself. To put it very succinctly, the biologic width basically refers to the dimension of soft tissue, which is always a combination of epithelium and connective tissue, the dimensions of soft tissue that are necessary to protect bone. And as we know, the oral cavity, the presence of teeth makes the system an open system, so that you now have not, because you have teeth and a sulcus, you have very little separating the bone from the outside environment. And the dimensions of those tissues that constitute this protective mechanism, when they're put together, is known as the biologic width around teeth. Around implants, we've learned to start to use a different term in place of using the biologic width. Biologic width was first described by Orbens and Gaggio back in 1961, where they spoke about the dimensions of the junctional epithelium and connective tissue as about a 2 millimeter zone. Again, it was redefined back in '94 by Wacek et al., and they spoke about around about the same kind of dimension. So we basically know that you have about 2 millimeters of epithelium and connective tissue put together, of which about half of it is epithelium and half of it is connective tissue. And in these initial definitions of the biologic width, the sulcus dimension was not taken into account. And if you start to take the sulcus dimension into account, we know that there would be about 3 millimeters of tissue separating the outside environment from the crest of bone. So this is what we have around teeth. What's important and interesting to also note over here and understand here is that this periodontal structure here, that is the marginal gingiva, is receiving its blood supply from three sources. That is from the periosteum, from the supraperiosteal plexus, and from the periodontal ligament itself, right? As well as from the alveolar bone. Now that those three structures are now reduced to one structure, and that is periosteal blood supply when it comes to thing, and to an extent from the alveolar bone itself. The other thing to note over here is the distribution of the fibers, the dentogingival fibers that you have around a tooth, as opposed to what you see around an implant. You see an arrangement of fibers which is perpendicular to the tooth surface, and you have an actual insertion of fibers into the tooth surface, into cementum, what we know as the Sharpie's fibers. Whereas on the other hand, around an implant, you have no such arrangement. You always have only a circumferential arrangement of fibers forming a cuff, but not inserting into the implant surface. So, though there are some implant surfaces that claim to have the ability to allow fibroblasts to kind of channelize into microchannels on the implant surface itself, this perpendicular insertion is still not something that has been established very clearly in implants. So what this means is that the between the perpendicular fibers that attach to a tooth and the circumferential fibers that are found around an implant, the robustness of this attachment is far more in on a tooth than it is on an implant. The second thing that we need to also understand is that by virtue of all of these differences, the sulcus depths around implants tend to be much more. Okay, so between an implant and a tooth, you will find that implant will have a more of a probing depth in health as opposed to a tooth. So, why I'm making these points here is because we have learned to look at peri-implant pathology with the same kind of yardsticks that we were looking at pathology around teeth. We defined and treated peri-implant disease with the same kind of measures that we took to define and treat diseases around the teeth, that is gingivitis and periodontitis. And as we go along, we'll see the differences between the two, and then how and the reasons for treating peri-implant disease as a completely different sort of an issue. And this is again another just a schematic to show you the difference in the blood supply uh, around a tooth, which derives from the ligament as well. And the ligament supply is a very important part of blood supply to the soft tissue, the marginal soft tissue around the tooth. Okay. We also need to understand here that this thing which we know as the biologic width has two components to it. One of them is genetically determined. That attachment zone is determined by genetics. It cannot be altered. Whereas the part that is determined by anatomy is the sulcus. All right. So the sulcus is deeper around. I mean, it's just logical that where you need to see or where you will see more triangular or rectangular appearing teeth, you will have deeper sulcus as opposed to when you are looking at teeth which are more squarish in form. And that is the reason why you'll start to see deeper sulcus in the anterior zones, whereas the sulci in the posterior zones would be much less or shallower because of the anatomy itself. All right. This is a consensus report from the 2017 World Workshop on the classification of periodontal and peri-implant disease, and I think they have done a great job in rationalizing from the standpoint of clinical significance both periodontal disease as well as peri-implant disease. However, I do feel that there are certain shortcomings in the way they have gone about defining peri-implant disease. And as we go along, I'll try to highlight those, and we'll see how we can put the best of the available evidence to use in terms of trying to understand what goes on around implants. So in this workshop, they defined four, or they classified this whole thing into four different classes. They defined it as they defined peri-implant health. They defined peri-implant mucositis and peri-implantitis. And then they spoke about hard and soft tissue deficiencies around implants. So this is the gist of it all. These are the four headlines under which you can put peri-implant disease as per that World Workshop. But we do see other conditions, and there are some other defining factors which are not encompassed in this particular classification. We'll talk a little bit about peri-implant mucositis and peri-implantitis, because that is going to be the basis for understanding everything else that we will speak about today. All right. What is peri-implant health? It means that there is no clinical sign of inflammation. It's not possible to define a normal probing depth, unlike what you see around teeth. And this is one of the major differences between implants and teeth. And the reason being, like I said, anatomically, the probing depths will vary depending on which zone of the mouth it is in. You'll get deeper probing depths in the anterior zones, depending on implant connections and platforms and where you place those implants. You will again find that probing depth could differ irrespective of the zone. So that's the reason why we can't define. And therefore, unlike what we associate with teeth, and this is again the problem with understanding how peri-implant disease was being defined in the past, because we were applying the same yardsticks. So if you found that the depth of probing was greater than, and you said 3 millimeters, you're able to probe. 3 millimeters is definitely a pocket around a tooth, but 3 millimeters is normal probing around an implant, because anatomy dictates so. So we need to differentiate these anatomical and genetic uh, the genetic variables over here, because that is what is going to allow us to know whether this is a normal probing depth or not. There is no such thing as a normal probing depth around an implant. All right. Then we will also, if you look at the histology of peri-implant health, you have a sulcular epithelium and a junctional epithelium. You have a connective tissue zone apical to this junctional epithelium, and in contact and this is in contact with the implant surface with very little inflammation. There is no cementum, no periodontal ligament, and no connective tissue insertion, like I already told you. And again, like I said, depending on where this is located, if you're using a one-piece implant or you're using a tissue-level implant, the sulcus depth will be very minimal, because the zone of junctional epithelium actually becomes much more in those situations. So collectively, the biologic width or the supracrestal complex will still have the same dimension of around about 3 millimeters, but the probing depth in this situation will be very, very minimal, because the sulcus is very shallow. And this is typically what you would see around tissue level implants like this, because sulcus depths are very, very shallow around here. Around bone level implants, and when you are starting to look at anterior zones, bone level implants, typically you'll start to see much deeper sulcus depths. And we now know that to be able to protect bone from animal studies in the 90s by Herban and Berglund and Linde and company, and from clinical observations by Linkevicius, etc., we know that to have at least a 3 millimeter zone of attached vertical tissue over the implant, over bone level implants, you need that much much tissue to be, or I mean, any kind of implants, you need that much tissue to be able to protect the osseointegration. So the dimension of 3 millimeters has become like a benchmark to keep achieving uh, that that thickness on the vertical in the vertical dimension over the implant, and that may be manipulated by varying depth of implant placement depending on the kind of implant system that you use. And once again, to show you that that when you are dealing with the anterior aesthetic areas, you need to place your implants that much deeper to be able to achieve the emergence profiles to achieve the aesthetics that you need. And the minute you start putting your implants deeper and you are expected to have a papilla and 3 millimeters of soft tissue on the facial side, you know that the sulcus depths in these areas will start to increase much more, right? So you will end up with minimum of 3 millimeters on the facial and up to 4 to 6 millimeters on the proximal surface, proximal sides of the implant. The It does not end with a piece of titanium that's inserted into bone and covered with tissue, right? The restoration is what is going to come in here and going to alter the dynamics of this whole thing. And when you introduce a restoration, it's like a bionic system. You turn this whole complex into something like a cyborg. There is a biological, it is a biological entity with mechanical parts, right? You have mechanical parts because you have a metallic abutment which has a connection and you have a screw that holds it down. And there is also the ability for this to move about as and when there is function, and there is some amount of micromotion that takes place because of the function that your implant restoration is put under. So you now have all of these zones. Once the prosthesis comes into place, you have a sulcus, you have a junctional epithelium that will attach onto the restoration and partly onto the abutment. And the connective tissue, this is particularly in those situations where you're able to place your implant below the level of you'll have a connective tissue that covers. So this whole supracrestal complex is is going to have to establish on top of the crest of bone. When this supracrestal complex is established, and then you add a prosthesis, you have an abutment, you have a screw here and a restorative material, which is most of the time a metal ceramic or a ceramic or a zirconia or whatever. You want to place or you want to design this restoration in such so it is I mean, there is no way that you can avoid bacterial contamination of your restoration. It's completely inevitable because you're introducing it into the mouth. There is saliva, there is circular fluid, there is all of those things that are going to contaminate the surface. But you want to be able to design your prosthesis in such a manner that it does not permit the growth or at least impairs the growth of a biofilm, because it's not just bacteria. You just have bacteria out here. It's not going to cause a peri-implant disease. The bacteria have to be present in the form of a biofilm, and that is what is going to give you a peri-implant disease whenever that happens, and that is the crux of the matter. So while you cannot avoid the bacterial contamination, you want to prevent the formation of a biofilm, which is the cause for the. And for this reason, you may want to you may want to design your restorations in such a manner that you have attachment and you have a seal at the crestal level, so that you now when you are inserting this restoration, the attachment of the connective tissue and the junctional epithelium takes place apical to the region where your restoration itself is, and now this becomes a very let's say, it becomes a much more robust arrangement than when you are, trying to push a restoration that goes deep into that sulcus and sits right over the implant. You can also do this with, with abutments that move the connection away from the implant itself. And with abutments like this, which are multi-units, you have a very robust peri-implant, the supracrestal complex, and you do not have any kind of, it's very resistant to biofilm formation onto them. Therefore, these kind of restorations last for very, very long without any kind of bone loss or peri-implant disease or signs of inflammation. Peri-implant mucositis, on the other hand, shows bleeding on probing and other signs of inflammation. It could include a little bit of a swelling, loss of stippling. You could have suppuration. There will be some exudation, of course, that you will see. There will be an increase in probing depth, and this probing depth increase, meaning increase now because you should be knowing what your original probing depth probably was. I mean, if you made your notes right, you will know how much the sulcus depth was to start with. And because you now have swelling or reduced resistance to probing, you will have a little increased probing depth, but there is no evidence of bone loss. So by definition, peri-implant mucositis is restricted to the tissues that are above the, the crest of the implant and do not go below the crest of the implant. So it is maximum at the most lateral to the bone and never extending apical, lateral to the junctional epithelium and never extending apical to it. And the infiltrate is typically a plasma lymphocytic infiltrate. And this is typically what you may see, some bleeding on probing, but there is no evidence of bone loss. Peri-implantitis, on the other hand, now peri-implant mucositis was plaque-induced. Plaque is the biofilm that we spoke about. Peri-implantitis, on the other hand, is again plaque-induced, but shows progressive loss of bone. That means there is an extension of the inflammatory changes that we saw in the peri-implant mucosa, going beyond the lateral to the junctional epithelium and going apical to the junctional epithelium, resulting in loss of, attachment of connective tissue as well as loss of bone. And it will always be preceded by a peri-implant mucositis. There will be bleeding on probing, suppuration, and increased probing depths, along with recession in some situations. What is interesting is that at this point, there are no specific bacteria or pro-inflammatory cytokines that are associated with peri-implantitis. And histologically, it's a plasma lymphocytic macrophage and neutrophil infiltrate extending apical to the junctional epithelium. And when you start to see suppuration like this and deep probing in this manner, along with radiographic evidence of bone loss like that, you know that you're dealing with peri-implantitis. And the same situation here, you've got bone loss and you've got progressive bone loss. And clinically, there is an increased probing depth and suppuration. All right. So what are the risk indicators over here? The risk indicators for peri-implant disease are a history of periodontitis. I mean, they say severe periodontitis, but a history of periodontitis, poor plaque control, and that stands to reason. I mean, if teeth were not kept clean, there was periodontitis, and the same applies for implants. But with implants, there are many more factors that come into play here, including the positioning of the implant to the fabrication of the prosthesis, because all of those factors will result in or will influence the ability of a patient to maintain plaque. There is inconclusive data on smoking and diabetes at this point. Cement in the sulcus is something that has been blamed for peri-implant disease and for for implant loss as well. Again something very difficult to conclusively establish. Uh, Peri-implant keratinized tissue, the lack of it, occlusal overloads, titanium particles, micromotion, biocorrosion, etc., are all associated with the evidence at this point is kind of weak. But the focus right now is on the on titanium particles and I mean their role in peri-implant disease. So if you want to get a, a good handle on the current concepts in the etiopathogenesis of peri-implant disease, these are a couple of articles that are probably the most comprehensive at this point. Uh, this one by my friend George Kostakis, and strangely, both of these articles seem to have a very heavy Greek influence over there. George is Greek, as well as this article is from a Greek group uh, in the European Dental Journal. This one is in Perio 2000, which talks about the difference between peri-implantitis and periodontitis, and how peri-implantitis is not periodontitis. Uh, one of the one of the problems that we've had with understanding this disease is that we were again placing the same yardsticks around implants and the disease around implants as we were doing around teeth. And for the last decade or so, we've been continuously treating peri-implant disease in the same manner as periodontitis has been treated. So we've been doing antimicrobial and mechanical treatment that has been used for peri-implant for periodontitis in the same manner, and then found that these treatments were ineffective. Then we know that both these diseases are biofilm associated, but there is a difference in the I mean there is a similar phenotype of the inflammatory response that are related to the bacterial biofilms for both of these, and this led again to the assumption that they are the same kind of pathogenic mechanisms. However, the rate of bone destruction is vastly different between the two. Uh, and this may be, there are multiple factors that are involved here, including the macro design to the chemical composition and the micro design, micro texture, etc. of the implant surface itself, and the response of bacteria to that particular texture, because you have now titanium versus hydroxyapatite substrate on which the biofilm is being formed, and whether whether they will behave exactly the same is a question that needed to be answered. And at this point, I think we have sufficient answers, and that they are completely different, right? The basis of on the I mean there is so for those of you who are also inclined towards restorative dentistry, and if you go into that literature, you'll find that the dental plaque that forms over a restorative material, for instance, like a composite or an amalgam, has a completely different composition from the same from the dental plaque on the tooth surface of the same tooth. Okay, you need to, I mean, this is very interesting, because it means that different substrates attract different organisms, though it may start with the same old mechanism of forming of a dental pellicle being, a salivary pellicle being deposited, on which You have the first inhabitants being strep mutants because of their adhesive capacities. Strep Streptococcus species, basically, with their adhesive capacity, maybe strep mutants. In fact, at this point, there is a lot of focus on strep subrinus as well. But beyond that, the population that exists in a periodontal pocket is vastly different from what exists in a peri-implantitis situation. And this has been established by an analysis of adjacent peri-implant and periodontal microbiomes in health and disease. And they found that of 85% of individuals, less than 8% of the abundant species were shared between teeth and implants. And so, where you may find a whole lot of actinomyces nicelunae in a periodontal surface, a periodontal pocket, you will find a lot more Veillonella species in a peri-implant situation. And so, this is one of the major differences. The other major difference is that the diversity of the of bacteria in a peri-implant location is far less than that of a periodontal location. Okay. There is also the suggestion that a peri-implant disease may result from a foreign body reaction, again emphasizing the role of the host response in disease initiation. Now, this is a model from Daubert et al. And Darboud et al., who spoke about, who presented a theoretical model of the formation of peri-implant biofilms and their progression. So the early implant biofilm has heavy diversity, right? Because it is in a supra crestal situation with the restoration from where so there is the oral environment and the sulcus from where the sulcus of neighboring teeth from where the bacteria are going to be transferred. And so that diversity that existed in the teeth is going to be transferred to the peri-implant environment. But then, if you're going to treat that, then you will end up with a drug-resistant biofilm with a preponderance of beta-lactam resistant bacteria. At the same time, there is titanium that is undergoing a corrosive phenomenon. We'll talk a little more about that. And there are particles of titanium which are being expelled into the peri-implant environment, which results in an opportunistic increase in metal-resistant strains of bacteria that leads to reduced diversity of the bacterial film or the biofilm over there, which means that it is now it's a much more narrow spectrum that you have to try to deal with leading to a preponderance of beta-lactam resistant strains, metal-resistant genes which would be expressed. There is continuing biocorrosion because of the bacteria being present there now, and I'll talk to you a little. So this is like a perpetuation of the phenomenon because more particles and greater inflammation, clinical inflammation. Greater the clinical inflammation, more are the titanium particles that are being that are being expelled into the peri-implant environment. The potent lipopolysaccharides are released and toll-like receptors are activated. Let's talk a little bit about these titanium particles. They may be generated as a result of an electrochemical process, which can be released into this biological milieu, right? The ions and particles are also released as a consequence of wear, right? So you have, like I said, this is a cyborg. You have a mechanical aspect to the whole arrangement. So as there is function, there is a connection between the implant and its abutment, and the restoration and the abutment. And as that function happens, there is some amount of wear that is taking place. There was wear that took place at the time of insertion of the implant. You drove the implant in with a reasonable amount of force, and as you were driving that implant in, the implant was being abraded by the surrounding bone, and titanium particles were released. So this kind of phenomenon of release when there is mechanical trauma is known as tribology. Uh, Corrosion, on the other hand, is taking place on account of chemicals over there, and which in the oral environment is abundant. I mean, any biological milieu, there is an abundance of electrolytes which can bring about that electrolytic uh, corrosion. Now, when there is a combination of the two, you call it tribocorrosion, and that's what happens in this particular environment, because there is a mechanical component as well as a chemical component, allowing an electrochemical component, allowing for corrosion to take place. Now, these ions and particles are released as a result of different mechanisms, like I said, at the time of implant placement, result of micro movement, and the wear which is generated by debridement of implants. Now you have somebody who's come to you for a thing, you do a cleaning, and you've actually released titanium particles. Okay, probably one of the Almeida was the second author in that article of periodontitis and peri-implantitis by Georgios Kotsakis, and he there. This is probably one of the groups that has done the most amount of work on systemic and local tissue responses to titanium corrosion. And you know, I just put this out here because this is not something that is going to go away. We know, if you look at orthopedic literature, and orthopedic literature, you will find more because the joints are large, right? You're replacing a hip or you're replacing a knee. Those are big and they are much more load bearing than a dental implant, and therefore the amount of titanium particle, the corrosion and the tribocorrosion that's going to take place on those implants is a lot more, and you will have a large amount of titanium ions and particles being released. But this is, with the number of implants being used, I think we have to be well aware that we are going to be seeing a lot more of patients with systemic and local effects of this titanium release into the peri-implant environment. Accumulation of particles in the liver, in hepatocytes, leading to impairment of liver function, has been shown in a few studies, one by Istvan Urban et al. Back in 2000. I have seen a patient, the father of a dentist, who developed an autoimmune hepatitis, and this was subsequent to his first few dental implants that were placed. Enough for the clinician who had placed those implants to abort further implant therapy, because the patient had a hepatitis which they could not, which was without any kind of etiology. Uh, I mean, I did suggest to them that this was possibly one of the mechanisms, but unfortunately, the patient, I mean, he did not make it. He expired because of the autoimmune hepatitis. But there is some literature to show that this sort of a phenomenon might occur, and it may be related to. There's another, another case that was referred to me from the mother of a dentist who's also a very prominent anesthetist in one of the big cities in this country, had implants placed, and within a few weeks developed the most inexplicable hemolytic anemia, and her hemoglobin never went up above 5. So I mean, he took the mother to another senior oral surgeon who got in touch with me, and I told him that it is very likely that, she's got titanium hypersensitivity, and getting those implants out actually, ended the problem. All right. So let's try and take a look at the pathway of corrosion and how their biological adverse effects take place. And we know that for osseointegration, this phenomenon to occur, you need initially a corrosion product to form on the titanium surface. Between taking your implant out, putting it into the osteotomy, and all of that, you are developing a layer of passivity. This passive layer is that of titanium dioxide. What happens in that environment where this titanium dioxide passive layer is disrupted is that there is no repassivation capacity because it is an anaerobic environment. All right, and this will, this perpetuates the problem, and you have I mean, the original lack of passivity or loss of that passivity layer may be related to local issues like dietary or inflammatory, etc. But then fluorides in this environment, which will perpetuate the problem and reduce the repassivation capacity, and you will continue to get more and more titanium corrosion products getting out, particles getting out into the peri-implant environment. Then there is a release of this titanium ion and debris so you have titanium which corrodes, and these ions and the debris are being now released into this peri-implant environment. And your immune system comes into play, and you have macrophages and T lymphocytes in that region, along with multinucleate giant cells, leading to some amount of epithelial necrosis, titanium particles being phagocytosed, titanium particles being found inside of the epithelium, and then you get to start with the mucositis and then the hard tissue reaction in the form of loss of bone. One such article from back in 2017 is by our own Dr. Tarun Kumar, who's sitting in with us right now as the expert here, and they established that the incidence of titanium particles in exfoliated squamous cells actually increased with increase in clinical inflammation. This is again from the article by Kotsakis and Almeida, where they showed cytologic smears, pap smears of exfoliated epithelial cells showing titanium particles inside of them. The other thing that happens is, apart from the titanium particles, you also start, I mean, once you get this kind of, apart from them being seen inside the epithelial cells, you also see them in macrophages. And very, this is what you would see if you were to take away a restoration which showed this kind of biocorrosion taking place. You can see that this abutment has undergone pretty significant corrosion. And when you look at it at a macroscopic level, you can see the titanium particles actually inside of the epithelium. So this is to an extent a titanium tattoo that's taking place in the peri-implant soft tissue. And it stands to reason that you will have some amount of mucositis and bleeding on probing, etc., because this will now perpetuate the inflammation. I have also seen a few patients like this showing this kind of a keratosis and a very poorly defined. I mean, there is no name that you can give to this kind of a lesion in the vicinity of dental implants. And these can be sometimes alarming because these are the sort of lesions that may transform into ear squamous carcinomas. Uh, when you have this perpetuation of the inflammation and bone loss proceeding, you see bones stripping off of the implant sometimes enough for it to just pop off. And you can see here that there is, though there is a very clearly a large amount of debris here, there is also a biofilm that has gone, that's grown on the implant surface and led to its loss. This is one of those where you don't see anything that appears like bone loss, but just trying to. I mean, this patient came to me. He had these implants placed at some other practice in Bangalore, and he came to me with a complaint of mobility. And initially, I thought it because when I look at a radiograph like this, there was nothing to suggest that this implant is failing. So I said, it's probably just an abutment that's loose. Let's get the bridge off and see what's going on. And I held the bridge, and the implant came with the bridge. You can see that there is a significant amount of what looks like cement here, but it might just as well be calculus. And you can see that there is a total loss of osseointegration with a total stripping of bone around here. And this was what was seen on the inside of the osteotomy that held that implant at one point. When I go I mean, this like it's almost like an epithelial membrane that was lying in there. The second implant, which I mean, so this whole thing happened exactly 3 months ago, and I happened to see this gentleman yesterday on my chair. The second implant, at that time when I checked the implant stability quotient, I had a reading of around about 60, which is not a good stability quotient for loading an implant. And 3 months later, when I checked it yesterday again, I found that it is still at 60. That means that despite the fact that it looks hunky-dory here, there is a loss of implant stability, probably because there is some kind of fibrous union or something else that's going on, which has stripped the osseointegration, and we are going to probably lose that implant as well. Friend of mine, Dr. Yazad, and Neil's birthday today. Between the two of them, they reported this case of a cystic epithelial lining seen around a dental implant. The histopathology was done by none other than our own Rajiv Desai. But I believe that what was reported as a cystic epithelium was an erroneous report, and it was basically an implant that had lost osseointegration and ended up with getting epithelialized, the tract getting epithelialized over time. We do have some articles which talk about titanium allergies and hypersensitivity. And like I told you about a couple of patients that I have come across who I believe were hypersensitive to titanium or allergic to titanium, or developed autoimmune conditions because of the titanium particles being released in the peri-implant environment. And there are, the manifestations of hypersensitivity to titanium may include local manifestations like hives and edema, etc., to manifestations at different places, different distance, at a distance from the location of the implant. and you may have disseminated eczema, edema, reddening, and so on. You may have systemic reactions, which include weakening of orthopedic implants and disturbed fracture healing and nervous disturbances, etc. This was, from Biology 2020. I mean, from Biology in 2020, which spoke of a series of, which was basically a systematic review of, of allergy and hypersensitivity to titanium, and it laid out a few papers that qualified for the systematic review on, I mean, of dental implants, right? And there were, I mean, there are several patients who have reported a lot of clinical signs of systemic and disseminated signs of titanium allergy. And so this is something that we have to be aware of because of the use of titanium implants increasing more and more in our in dentistry. This is another review article from Contact Dermatitis, which speaks about a lot of these patients reporting with systemic and localized systemic and disseminated manifestations. The way to establish whether a patient is sensitive or hypersensitive to titanium or not is using the MELISA test, which is memory lymphocyte assay, and I think this is something that we are going to see much more of because, and it's not as though zirconia implants are, any different. There are similar reports of problems with zirconia implants. It's the same as what happened with silver amalgam. We said silver amalgams cause lichenoid reactions, and we found that you get lichenoid reactions with composite restorations as well. So, there will be, I mean, there is no such thing as a completely inert material. Whatever is implanted will have some kind of, there will be some reaction to it. Uh, Whether it is a subthreshold reaction which does not create any clinical manifestations, or it crosses the threshold and shows clinical manifestations, is what is going to define whether that patient is going to show signs of disease or not. Then we will talk a little bit about drugs and osseointegration. Something that is now catching up as a potential, uh, I mean, a potential drug from the standpoint of loss of osseointegration. I have personally seen 3 patients where I've had disastrous results with dental implants after placing them when they were taking selective serotonin reuptake inhibitors. Bisphosphonates has been spoken about for a long time. We will talk a little bit about bisphosphonates. Then there is denosumab, again an anti-resorptive agent which is used in malignancies and osteoporosis. And then you have others which are like the proton pump inhibitors, methotrexate, which all have lower levels of anecdotal evidence. So let's take a look at SSRIs, and some of the SSRIs that we know of are citalopram, dapagliflozin, etc., zimilidine. Um, Now, this particular article from 2014 concluded that SSRI treatment was associated with a higher risk of osseointegrated implant failure. And this is one of my patients. I placed a couple of implants for this very good friend of mine. And, a couple of weeks later, she called me saying, I'm feeling very, very uncomfortable. I don't know what's going on. And the problem is that though she's a good friend of mine, I had I had no idea that she was on SSRIs, because somehow these patients don't like to reveal that in their history. So there was no history of. In fact, at that point in time, I wasn't even aware that SSRIs were, caused or had any kind of an impact on osseointegration of implants. It's only after this that when I started to dig deep into her drug history and started to dig into literature to see which drugs could cause this sort of a problem, that I realized that it was the SSRIs. Uh, and this was disastrous. This was like bone necrosis, enough to have left her with a big gaping hole over here. And I mean, uh, she's been consigned to wearing a denture because she doesn't want to go through major surgical procedures anymore. So this was one of those massive disasters where I had to take those implants out and just leave her with a massive defect than that. This, on the other hand, is a paper from another group which has greater credentials, of course, because this is from Malmo, and this is Anne Wennerberg's group, which spoke about the possibility that SSRIs may not be associated with an increase in the risk of dental implant failure. Medical literature, however, shows us that the pharmacological literature shows us that using antidepressive agents like SSRIs has an impact on the bone mineral density, particularly in women. And I mean, with all the work, the research that I've done, we've also seen that the patients who are on long-term SSRIs show very insufficient or very deficient vitamin D levels, and that's possibly the reason why you have uh, these implant failures and these kind of issues with bone healing in patients who are taking SSRIs. Bisphosphonates are used for largely for osteoporosis. Apart from that, for patients who are undergoing chemotherapy for various malignancies and bone metastasis, multiple myeloma, etc. Now there are two classes of bisphosphonates. So there are the non-nitrogenous, and then you have the nitrogenous. Of the two, the more potent and therefore the more toxic are the nitrogenous or the nitrogen containing uh, bisphosphonates. And the ones that are used in, so you may have, for instance, an ibandronate could be given orally as well, right? But that's what ibandronate has a very high toxicity or potency when related with etidronate, which is the bottom of the scale here. So having said that, we also know that patients who receive intravenous bisphosphonates, particularly the nitrogenous bisphosphonates, show a higher risk uh, of developing bisphosphonate related osteonecrosis of the jaws. The reason, and there are no other bones that undergo this kind of osteonecrosis, at least there is no such literature available. And the reason for this is that the alveolar bone proper is really the most turning over bone in the human body. We know that, right? That's the only place where you will find woven bone in a normal situation, and that means that it is constantly turning over. The way bisphosphonates work, and the large, main mechanism by which bisphosphonates work is by inhibiting osteoclastic resorption, right? It does not inhibit osteoclast production or recruitment but it does inhibit resorption. Interestingly, when I see biopsies of patients who had bisphosphonate osteonecrosis, you see good numbers of osteoclasts, which are not doing their job. And therefore, you see lots of dead bone, but no resorption taking place. This is, from Christian Walter and their group. This is a great group working out of University of Mainz. And Christian was here. We were fortunate to have him do a lecture at the ITI Study Club in Bangalore a few years ago. And he's probably one of the biggest authorities on bisphosphonate osteonecrosis of the jaws. And they picked up articles and did a review of the mechanisms that have been implicated in how this bisphosphonate associated osteonecrosis takes place. Most of it talks about the fact that you don't have apoptosis. Another interesting issue now is that there may be an anti-angiogenic, component to this, which is more alarming, right? Because there is, if it starts to also become avascular, then what is the extent to which you can go in terms of, and this is something that I'm suffering with this patient of mine. And this is not, she was on an oral bisphosphonate, oral hydrophos, which is ibandronic acid. We've been treating her now for, she has undergone 2 surgeries. At a point in time when I could not operate, there was a good friend of mine who operated upon her, got rid of much of the dead bone. Then she was treated by another surgeon, and then eventually came back because everything went back to square one. And right now it's right just above the imperialveolar nerve. She was symptomatic all along, but I've been treating her now for some time with photodynamic therapy, and I can say that we've got about that much of bone exposed, and that's a big deal because it's really slow but steady progress in thing. But these are the most difficult sort of situations to deal with. All of you know what's happening right now with mucor. I mean, this post-COVID mucor epidemic that we are experiencing here in this country. And I mean, it is really, really disheartening to see, I mean, including the most competent surgeons being completely at wit's end as to how to handle those cases. And this is typically what happens with bisphosphonate osteonecrosis. This is what this patient looked like at presentation. Interesting that you can, okay, this is histopathology. Again, showing you large numbers of osteoclasts, right? But you can see that this is all dead bone and which is not getting resolved. There are osteoclasts which are just not able to do their function, not producing the acid phosphatase to be able to resorb this bone. What is interesting, and this is a patient with osteogenesis imperfecta who's been treated for, who's been treated with IV bisphosphonate for, I mean, I know her since she was 16 years old. She must be, no, not even 16. She must have been much younger when I first met her. And she is into her mid 40s now. So I've known her for close on 30 years. And I know that she's been taking IV bisphosphonates for over 20 years. She happened to have lost this. So this was also, there's also dentinogenesis imperfecta, as you can see from the radiograph, the obliteration of your pulp chambers and canals. Now she lost this bridge and came to me because her orthopedician told her, go ahead and get a dental implant done. All right. Now, if this is the state that we are in terms of, of understanding of a problem like this, which you and I know is a big deal of a problem, the orthopedician very nonchalantly told her to just get an implant because she lost the bridge, and I ended up giving her a new bridge. What you need to see, and these are very telling signs on a dental radiograph, which you can look at, particularly in an intraoral radiograph, and tell without thing, and that is the thickening of this lamina dura. You can see that lamina dura become almost really twice their thick. What used to be maybe less than a millimeter is now over a millimeter and a half. And the trabeculae themselves start to look far more radio opaque. All right. This means that this particular patient is at a risk for osteonecrosis. You cannot just take an incision here and leave this and allow this to, because what happens in these patients with osteonecrosis is that apart from all of this, you also start to get to see colonies of actinomyces. So they end up developing a osteomyelitis, which has an mycosis kind of appearance. The second drug, and these pictures are from my friend in Hyderabad, Dr. A.P. Mohan, and you can see that this patient has exposed bone out here. He was on denosumab for a malignancy that he was being treated for, and one extraction and the bone never heals, right? Now, these are patients that you do not touch, so you need to be aware of the kind of medications. All these anti-resorptive medications, as well as SSRIs, can cause these sort of issues. The last part of my lecture today is on oral squamous carcinoma and dental implants. And if you start to look at literature, you will find that there are several cases that have been reported now in literature between 1996 and 2015. There were 23 publications with 46 cases reported in literature. Of them, one of them is from our good friend Dr. Neil Bhattavadekar in Pune. And they tried to see if there was a possible relationship or an association between dental implants and squamous carcinoma. They could not establish a cause and effect relationship. If you remember, I showed you one photograph with keratosis taking place on the palatal gingiva, and on the palate itself, there was an erythematous patch. Those are things that I believe are possibly from galvanism because of the use of dissimilar materials. There was a cast restoration on a titanium implant, a cast non-precious alloy restoration, and those sort of combinations could be far worse. And so I would, for those of you who do practice implant dentistry, I will tell you that you should stick to similar materials, and that means that if you're using a titanium implant, make sure that the abutment, the connection, and all of those components are titanium, and maybe metal-free restorations, because that would mean that you do not have the ability or the possibility of any kind of galvanism. We've all done this in the past, but as we gather knowledge, we should be more, we should use that knowledge to the benefit of our patients. And nobody has been really able to. This is the report from Neil back in 2012, and nobody's really been able to establish a relationship or a plausibility of the previous hypothesis of carcinogenic mechanisms, which which could be because of the corrosion, because of release of titanium particles, etc., from into the peri-implant environment as being causative of squamous carcinoma in that area. So no, there has been no kind of conclusive evidence to to establish that. And if you, I mean, it's just a matter of applying logic to this. The number of dental implants that are being placed and the prevalence of squamous carcinoma that is there, particularly in India. All of us should have been seeing a lot more cases of squamous carcinoma in relationship to dental implants or in the vicinity of dental implants, which is really not so. Again, an article from Wilfried Wagner and company in the University of Mainz. Dr. Wagner is like one of the most respected figures in implant dentistry, and again, they have made the same conclusion that it's still an open issue, that there is that peri-implant carcinomas are not a specific entity and just a variant of other or just part of the whole spectrum of squamous carcinomas. Having said that, I have seen 3 patients now with squamous carcinoma in the vicinity of dental implants, and this is one of those. This lady uh, had oral lichen planus. She was treated with this particular implant at another friend's clinic, and she was referred to me. So she used to come to me earlier with her oral lichen planus, and then she had an implant placed over there, disappeared for a whole lot of years, showed up in 2016 because she was referred again by the same clinician. And this is what I saw. Uh, Starting here and extending into anterior to the to that implant. This is the implant restoration. You can see the tumor there. Some amount of bone loss, but you can see the amount of soft tissue that is proliferating over here. Histopathologically, it was a grade 3 squamous carcinoma with some amount of acantholysis. And I have not seen this patient since 2016, but this is something that we need to be aware of with the increasing number of implant use and with the number of squamous carcinomas increasing. It is going to be just a matter of time because each one of us sees before each one of us sees a case in close association with squamous carcinoma. So in conclusion, I would like to, apart from all of this that I've spoken of, there are some other things that need to, I mean, the scope of this lecture did not permit it, but there are things like, serum vitamin D and serum cholesterol, which seem to be impacting. I mean, serum vitamin D makes sense because it's always been something that we need to be cognizant of and take uh, good notice of before we plan implant therapy. And it's almost protocol in my office that every patient goes through a serum calcium to make sure that, I mean, that we see serum calcium, serum vitamin D, and a parathormone assay. I have started including cholesterol, total cholesterol, and the LDL levels because we have some support in literature now to suggest that high levels of total cholesterol and LDL may result in early implant loss. So apart from diabetes, there are more things for us to be concerned about than just diabetes. Having said that, I will conclude by saying that the peri-implant supracrystal complex is a very special environment. It's very different from the periodontal complex, and the microbiome of the peri-implant complex is also totally different from that of what we see around teeth. And therefore, the mechanisms that lead to peri-implant disease are cannot be measured by the same yardstick and treated by the same measures that we take for periodontal disease. Okay, um, so though it is, I mean, it is biofilm induced, all right, The biofilm is composed of different kinds of organisms, and the bone loss that takes place around implants is far more rampant than that around teeth, and it is not responsive to the conventional therapies that we use around teeth. Right? We have to be more aware of titanium allergies and and there are I mean, I have a patient who I placed an implant for way back. Okay, I know. I mean, I'm talking about 2007 or 8 or whatever. And a few weeks after that, his wife came and told me that this man died, and I can tell you that to date, I don't know whether it was related to. They said we don't know what was the problem. He had sudden liver failure and he died. And it was a single implant that I placed in the upper premolar region for him. And you know, the thought that it was probably related to uh, a hypersensitivity or an autoimmune condition or hepatotoxicity from the implant has kept me awake for many a night. All right. So I think we should all, get a little more aware of these possibilities. If need be, get our patients go get an LTT or a MLISA done to check our patients for sensitivity. Especially take a history of of allergies to metals. So if they do say that they are allergic to various other metals, maybe it's a good idea to get them tested for titanium sensitivity as well. We know that I've spoken a little bit about some of the drugs that can modify bone behavior after surgical trauma, like extraction and implant placement. And though there is very weak evidence, we should be aware of the possibility that you may see squamous carcinomas in the vicinity of dental implants, not necessarily because implants can cause them, but more so because there are lot of implants being placed and a lot of carcinomas that we see. Thank you once again, Dr. Mandana, for this uh, fantastic opportunity to speak about pathology and implants. And thanks, Sudhindra, for that, for moderating, for that wonderful introduction, etc. Thanks.
Yes, wonderful, wonderful presentation. Now I'll let Dr. Kulkarni please take over, and I think there are a few questions. You can just
yeah. Thank you, Narayan, for a very enlightening lecture. The topics that you covered, right from the implant, peri-implant tissue complex, to titanium allergies, foreign body reactions, even the presence of titanium particles in epithelial cells, and all the way to oral carcinomas in the vicinity of implants, just goes to show that we tend to use a lot of biomaterials in our patients. It's not just the titanium, but so many grafts and everything. And our knowledge and what we are observing in our patients, sometimes an implant fails and we say, okay, you did not maintain it well or something happened in the implant loss. But we are not digging into the depths of what actually can be the final actual cause of failure or non-integration of an implant in our patients. Also, symptoms such as a burning sensation. This happened with a patient of mine. It happened with the base metal. When the implants were done, the restorations were placed. It's a porcelain fused to metal restorations. And within 2 days after the delivery of the restoration, the patient complained of continual burning of his tongue. He didn't have any other symptom. There was no redness, but he always had a consistent burning of on the tongue surface. Eventually, after probably 2 months, I knocked off the entire restoration, gave him PMMA restorations, and then the symptoms vanished. So we just don't know to what material our patients react in which particular manner. So you probably listed out so many of them, and I think it's very important and imperative for all of us to start looking at what can be the actual cause for discomfort in our patients, even after probably the best possible work has been done for them. Thank you so much, Narayan. There are a couple of questions. Here. I'll just read them out. Question number 1 is the importance of biologic width is paramount. Are there any considerations that a minimum of 4 mm of biologic width is absolutely necessary for implant success? and how you can establish that 4 millimeters?
I think I spoke about that at length,
Yeah.
that you need a 3 millimeter vertical thickness of soft tissue, which is attached above the crest of the implant. And I also spoke about how you could modify that by virtue of depth of placement and the kind of, so you can substitute. It's basically about volume. So you can substitute vertical dimension uh, or you can substitute horizontal dimension for vertical dimension by reducing the platform of the dimension of the platform of your abutment, and that gives you a horizontal component to that biologic width. We don't use the term biologic width anymore in relation to implants. We call it the supracranial complex. But having said that, it translates to largely the same thing at this point.
The second question by Dr. Prashanti. Do we need to add any additional questions in medical history taking to predict/get clue regarding the titanium hypersensitivity in future?
Yeah, like I said, it's a good idea to ask about allergies to metals, at least, right? And many a time it could be something as innocuous as a earring, or or a finger ring, or whatever. In fact, for all that we know about gold as being a noble metal, and that you do not have reactions to gold. Gold is one of the biggest allergens that we have on this planet, right? So if you do find that patients are allergic or have reactions to metallic uh, jewelry and other this thing, so they might just as well be allergic to titanium. Might as well have them tested and look for an alternative. If you do not find titanium, if you can use a zirconia, use a zirconia or a ceramic, and that would be the right kind of approach there.
Okay. This is the last question what we have. Sir, can we hypothesize Koebner's phenomena as in OLP, where microtrauma, concomitant healing and repair hormones, and intense inflammation can be treated as etopathogenesis for oral cancer in and around a dental implant? Here.
No, I won't go so far as to think, and I can very well guess who has asked this question also. This is Abhishek Badranna who's asked this question, right?
Yes, I think it's Abhishek.
All right. So Abhishek, Koebner's is actually a skin phenomenon. We don't we believe that you see something like a Koebner's in the oral cavity. It's very so for that reason, for that this thing, oral lichen planus. When Eisenberg started speculating on the precancerous nature of oral lichen planus, or pre-malignant potential in oral lichen planus, if you start to look at the number of patients who actually suffer oral lichen planus, the number of oral squamous carcinomas should be 20 times that we see right now, right? It's not so. So if we still, we have to be more, let's say, pragmatic in the way we look uh, at at these uh, these variables. Yes, you have titanium particles. They come out. They're there. They sit in the thing. They go to distant places. They are found. They have been found in the liver in several other patients. But it's very difficult for us to establish they are that is responsible for carcinoma. Perpetuation of inflammation. We've there is this age-old concept that continuous inflammation and mechanical trauma. Yes, but that would have to be that it is a malposed implant with a very malposed and malformed and broken down tooth, which is constantly. So there are too many things that have to be wrong in that particular setting for it to be the causative for something like an oral carcinoma. Dr. Mandana, would you like to say something about that?
Well, yeah. The thing is, what I also feel is that it would need, although we know now that chronic trauma can cause and can be one of the factors for oral cancer. But like you said, a lot of things have to go wrong for there to be that much of trauma there at that point. And I have to say, I don't know anything about implants, so I'm not going to comment on that part. But yes, as far as the oral cancer goes, I think it's going to be it's a tough situation and a very rare situation for us to find that.
Exactly.
But definitely, I think if you're finding, maybe if if you're finding that the neighboring tooth is malposed, or if the person has a lot of uh, periodontal problems, or maybe a pan chewing habit, and he puts the pan in there, I think all of those need to be taken care of simultaneously. Yes.
Exactly. All of the synergy. Yeah.
There's one more question that just come in by Joss. How sensitive is a skin patch testing for titanium allergy?
Skin patch is not the right way to check for titanium allergy. You have this thing, lymphocyte transformation test, LTT, and Melissa. Melissa is the more it's the more kind of definitive way to check for titanium allergy or hypersensitivity, right? Melissa is memory, lymphocyte, immuno, sorbent assay.
I think these are the questions for the session. I think I'll have hand it over to Tarun for his comments before probably we close it.
There was, I think, one query by on the supracrustal where they asked for minimum biological width. Narayan, would you like to say that there are sometimes you see bone which might be reduced, which can be reduced a little bit, like 2 millimeters, so that we can give that space to increase the soft tissue?
Yes, absolutely. Either reduce bone or push the implant in deeper, or I mean any of those kind of this thing, and that's how you could change the supracrustal dimensions.
Yeah, because most of the times, if there is no deficiency, there will be, you find the bone in conjunction with the adjacent interdental bone peak, whereas our implants need to be placed for the restorative space slightly below. So most of them, they don't consider taking this bone reduction. They just keep it at the in flush with the bone, and finally find that the restorative space is reduced, even their supracrustal attachment is less.
Yep.
There's one question that just come in by Dr. Nandini. What are your comments on implants and MRI investigations?
No comment. There's no bearing on MRIs.
Yes.
Yeah, there is really no. It doesn't make a difference unless you're going to image, that area where the implants are. In which case, there will be metal artifact, but it's not going to. It's not like the MRI is going to make your head pop out and go out to the magnetron or something of that sort. Nothing's going to happen.
Exactly.
That's only on House MD that you will see something like that happen.
Exactly.
And usually the implant, they are given that it is MRI safe, except for the components of the implants.
Correct.
Like here, the healing abutments or something like that. Some of the companies don't give clearance for these kind of components. So they need to be clear of what components, if it is a full arch or something, you have used so many components which can sometimes cause some issues. Otherwise, such implants, I don't think any issues.
Yeah, exactly.
But they are non-ferritic, metals and alloys. So in that sense, it's not as though it's going to fly into the. What I'm saying is, it's not going to be flying out of the mouth like that, making holes all over the place.
Yeah. The implants don't get magnetized, basically. They don't get magnetized. The only thing, the issue is you may end up with artifacts on your image. That's the issue that we can have.
Exactly.
Yeah.
Okay, I have a question before we end.
Yeah.
Now, you said that a major problem is that the biofilm has changed. The biofilm around changes and is altered.
Yeah.
Anyone is trying, probiotics on this to see if we can replace the original?
No. No, that not that I'm aware of. Not that I'm aware of. Yeah, maybe that's something that you could do in your PhD. No?
My PhD is a long saga. Okay.
All work out.
A few
Yes.
questions from my side. As usual, I am known for chewing Narayan's brain. So, Narayan, what is your opinion on this oxidative stress? You talked about vitamin D and its role in bone loss. These days, we hear a lot of these articles saying about oxidative stress and bone loss around
Free radical,
implants.
yeah. Yes, it is. I mean, it stands to reason. Yeah. I mean, it is. There will be. I mean, it's definitely related. There's no two ways about that. Yeah. So if you do get, I mean, you do get oxidative stress, you do get free radical release, and you will have bone loss around the rim.
Okay. And one more thing about the titanium particle and the corrosions, what we discussed. Many a times, a few years back, there was a lot of this titanium brushes and few of the brushes which came into the market to clean the implant surface during peri-implantitis. Now, whenever we are using that, that means we are removing some of the implant surface, which probably is a protection which is holding that particle back.
Exactly.
And once we remove this oxide layer, probably we are making it more prone for corrosion and more leakage of titanium into the tissues.
Exactly. So you're taking out the passivity layer, right? The passivated layer of titanium dioxide has been removed. Even just mere instrumentation by hand, not even necessary to have used the titanium brush. Just the regular hand instrumentation, and you are releasing titanium particles, taking off the passive layer. And because it's an anaerobic environment, you will not get another titanium dioxide layer happening over. So you will continue to perpetuate the corrosion that happens, which was stopped by the virtue of the titanium dioxide in the first place.
Okay. Now, Sudhindra and Narayan, anecdotally, do you find any of this? There are multiple of implant surfaces available in the market. And do you find any particular implant surface causing, sudden kind of bone loss, which cannot be correlated with many of the things we know already, but mainly related to a particular implant?
Yes, I mean, I do. There was one, the macro, I mean, actually the macro geometry of that implant had those huge spheres, and which was a very kind of dangerous surface, because there was no way that anything could get to the biofilm, and that was with the porous sintered surface from endopore. I also find that the same thing exists with the tionite surface from Nobel, also osseotype from the from 3i. I think all these three surfaces have a problem with their. I think that's the reason why a responsible company looks at modifying that, and I think that's happening now.
I've seen this even at the titanium plasma spray with Oraltron XPTC. The older design.
TPS,
TPS, titanium.
That's why they moved to PureTex.
Yes. So there's one more question which has just come in. In the pretext to different area of microbiome in and around dental implants, so is it better to keep them submerged than non-submerged? Will good oral hygiene maintenance will keep the microbiome at bay? I actually did not.
Even I didn't understand it very clearly, but I think I know what the question is about. There are two aspects to this. By submerging it, you have to expose it to the oral cavity. What's the point in placing an implant if you're not going to put a restoration on it? So you put the restoration. You have to design the restoration right to make sure that plaque control is possible, right? And that it is not just possible, that it is efficient. And those are the two things that you can do to ensure that there is no it is impossible that it will not get contaminated by bacteria. if it has gone into the mouth, there is saliva, there is everything else. Bacteria are there. So the adjacent sulcus, all of those bacteria will populate the restoration. There's no way that that won't happen. It's just that they should not be able to form a biofilm.
Yeah. These are two questions actually I have regarding, one is regarding your titanium particles. There are times when we have very, very dense bone. You've done the implant drilling and you try and place the implant. You see that the implant doesn't go into the full depth. Then you tend to unwind the implant, probably redo a drilling, and then try and place the implant all through. Okay. So every time we thread in and unthread the implant, especially when you're looking at getting very high torque, excess amount of torques, do you think some particles actually get displaced as we try and do this process? And can that actually determine success or failure of implants? Because we always seen if you have excess amount of insertion torque, some of the implants have lost. We've lost.
What happened?
I've lost you, Sudhindra.
Yeah, I think we have lost Dr. Sudhindra. Okay, he's back.
He's back.
Yeah. Hello. Yeah. I think you got the question.
Yeah. So yes, I mean, I think I mentioned it also in the thing that by just the friction of placing an implant, you can be, I mean, there can be abrasion of the implant surface, and you can have titanium particles going into bone, and that can, and having understood the mechanism of titanium particles and their role in peri-implant disease, it's very possible that you can get disease from there. There is this concept of compressive necrosis and so on, which is again something that doesn't have a very strong scientific basis, because like if that were the thing, high insertion torque, there are some implants which are designed to go in with very high insertion torque at 100 NCM and more. You should be getting necrosis around all those implants at all times, but it doesn't work. It doesn't work that way, and that's because of the designs and so on. But having said that, I mean, it makes sense then to use bone taps, etc., to make sure that the passage of your implant, or the insertion of your implant, is smooth and never beyond the recommended torque.
Yeah. Yes, I think we're done with that. Yeah, we're done with all the questions.
Yes, we are. So now I just have to share one second. So are you seeing that?
All right. Thank you.
Thank you. Thank you.
You're most welcome.
Thank you
so much.
Thank you for having us.
Thank you. Thank you.
Wait, I do have the rest of your certificates. That is only Narayan's certificate. Don't be in a hurry. I know very busy clinicians are in a hurry to get back, but 2 minutes more. Okay. So anyway, Dr. Narayan, for the longest time, as you know, I have always been slightly grudging about the fact that you're sharing your oral pathology time with other things, such as implants. But I think I have always told you this. But I think today I see the reason. Maybe this was always what you were meant to be and what you were meant to be doing. I think this is going to make a lot of difference. Yeah. Great job. Thank you for that.
Thank you. Thank you.
Yeah. And 1 second. Yes, Dr. Sudhindra, thank you so much for being here and for moderating the session.
Thank you, ma'am. Thank you so much. Thank you.
You're most welcome. And Dr. Tarun, thank you also for sharing all your experience and all the discussion that happened because of all three of you. Thank you so much.
Thank you, ma'am. Thank you for having me.
Thank you. And now I just have, of course, all the viewers. Thank you so much. And yes, with that, I have to say thank you. And see you all next time.
Okay.
Thank you all.
Cheers.
Thank
Bye.
you.
Thanks
Bye.
again, Mandana, for having me.
Thank you.
See you guys.
Bye.
Bye. Bye.